Hello, everyone, and welcome to the grand rounds for the Minnesota Regional Spinal Cord Injury Model System, or we call it SCIMS for short. Thank you for joining us today. SCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDLR, Spinal Cord Injury Model Systems Program. And the purpose of SCIMS is to support innovative projects and research in the delivery, demonstration, and evaluation of medical rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injury. Next slide. SCIMS represents an exciting new partnership among the following institutions: Courage Kenny Rehab Institute in Minneapolis, Mayo Clinic in Rochester, Regions Hospital in St. Paul, and University of Minnesota in Minneapolis. Next slide, please. Our community collaborators include the Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. And this system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical services, acute care services, acute rehabilitation services, and post-acute services. My name is Dr. Angela Hanks-Philippus, and I will be today's moderator. I'm a research professional in the Department of Rehab Medicine at the University of Minnesota Medical School and co-investigator with the SCIMS. Next slide, please. A couple of housekeeping notes. The University of Minnesota has organized the CME for today's webinar. Please see the chat information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. This meeting is being recorded and will be posted on the SCIMS website. To earn CME credit for today's presentation, please click on the link in the chat. And due to the number of registrants for today's webinar, we have placed the phone lines on mute to reduce audio feedback. However, we do welcome questions, and we ask that you please submit those in the chat to Dan Kelly. We extend a huge thanks to all of those who work behind the scenes to make these webinars possible. Next slide. The title of today's presentation is A Review of Spinal Cord Injury Physical Activity Interventions and Future Research Directions. The presenters, starting with Dr. Kimberley Monden, is a tenured associate professor, licensed psychologist, director of the Division of Research and Innovation, and vice chair of research in the Department of Rehab Medicine at the University of Minnesota Medical School, with experience in spinal cord injury clinical care and research. Dr. Monden's research focuses on psychosocial adaptation to injury, including resilience and injustice appraisals. She's interested in improving quality of life and long-term psychosocial outcomes after spinal cord injury. Dr. Monden also has expertise in dissemination and implementation science. She is the founder and director of the Spinal Cord Injury Psychosocial Outcomes and Wellbeing Research Lab, which is SciPower for short. And Dr. Monden is the project director of the inaugural Minnesota Regional Spinal Cord Injury Model Systems. She has funding from NIDLR, DOD, and the Craig H. Nielsen Foundation. Dr. Monden is a fellow of the American Psychological Association. We also have Michael Tschida, who was born and raised in Roseville, Minnesota. Michael attended the University of Minnesota for his undergraduate education and received a Bachelor of Science in Microbiology. Michael is currently a double gopher as a third-year medical student at the University of Minnesota, and he plans to pursue a career as an internal medicine physician with clinical interests in primary care and specialty care. Michael completed a directed research elective with Dr. Monden this past December that pertained to physical activity intervention literature review, assistive technology, and perceived injustice in individuals with spinal cord injury. And in the future, Michael hopes to apply the knowledge and skills from his research experience to provide high-quality, patient-centered care. So welcome to you both, and thank you so much for presenting. And go ahead to the next slide.
All right. Thanks, Angie, for the introduction. And thank you all for having me here today. I'm excited to talk about what I learned working with Dr. Monden and Dr. Hanks Philippus over the month of December. So starting off, we don't have any disclosures for today's talk. Um, an overview of what I'll be discussing today. I'll be going over everything that I read in my literature review. So reviewing the current physical activity guidelines, the traits and demographics of individuals who are already participating in physical activity, the benefits of physical activity, and then interventions that increase physical activity, as well as limitations of the existing literature. And then Dr. Monden later in the talk will go over future directions and research design. So reviewing the current spinal cord injury physical activity guidelines, it's broken up into two categories. There's the starting level, which is about 20 minutes of moderate to vigorous aerobic activity twice a week. And moderate to vigorous intensity is defined as moderate being somewhat difficult to hold a conversation while you are exercising, while vigorous would be very difficult to hold a conversation and mostly focused on breathing and getting through the exercise. And the starting level provides some fitness benefits, but really the advanced level, which is 30 minutes, 3 times a week of moderate to vigorous physical activity, is where you start to see kind of the cardiorespiratory and cardiovascular risk factor benefits of the exercise. Notably, the strength training requirements is 2 to 3 times a week. And why it's important to know these guidelines is first, it's just a minimum. Obviously, individuals can go above and beyond these metrics, but it's also distinct from other guidelines that have been described. So there's the WHO guidelines for individuals with disability, which is 150 to 300 minutes of moderate activity or 75 to 100 minutes of vigorous activity. And different studies will define what is physically active based on these guidelines. So it's important to know what they're actually talking about, whether their inclusion or exclusion criteria is a physically active 90 minutes of aerobic activity a week or 150 minutes of moderate activity a week can definitely change the outcomes of the research studies in this field. You can go on to the next slide. And so why is physical activity important in individuals with spinal cord injury? It's been shown that individuals with spinal cord injury are at higher risk for cardiometabolic syndrome, and there's a few reasons for this. One is that it's been shown that they have a lower resting metabolism due to their muscle paralysis. Normally, as we move around, our muscles will take up metabolites and activate certain metabolic pathways to help fuel the exercise and physical activity. However, when that's not occurring and increased sedentary metabolism takes place, it results in increased adipose tissue and increases the risk of cardiovascular events down the road. There is also an element of neurogenic dyslipidemia, which has been shown that individuals with spinal cord injury have lower amounts of HDL, or the good cholesterol that helps prevent cardiovascular events down the road, and have increased amounts of triglycerides after meals. It's also been shown that individuals with spinal cord injury have a 2 to 3 times increased risk for developing diabetes, and the obesity prevalence ranges between 67 and 97%. So it's important that we provide meaningful interventions to help mitigate these risk factors that are, non-modifiable to reduce the cardiovascular disease burden down the road. So looking at a few observational studies that were evaluating who is participating in activity. The first was a retrospective case control study in Australia, and they defined activity into two groups. The first being non-exercisers versus exercisers, being that non-exercisers are doing 0 minutes of leisure time physical activity versus 1 minute of leisure time physical activity. And what they found was that traumatic spinal cord injury etiology had a higher likelihood to be at least doing 1 minute of leisure time physical activity. Additionally, time since the spinal cord injury also seemed to make it more likely to be doing at least 1 minute of exercise. They also noted a correlation with higher health rating and health satisfaction scores as well. But since this is an observational study, we can't say that because they're exercising at least 1 minute that that's causing the increase in health satisfaction. It could be because they're healthier at baseline, they're able to participate in the exercise. The other component of this study looked at who is completing the spinal cord injury guidelines. And they found that about 10% were adherent to the physical activity guidelines, and found that, again, traumatic spinal cord injury and individuals who were unemployed were more likely to be guideline compliant. And so this study kind of gives us at least an overview of different populations within the spinal cord injury community, and potentially areas for future research. As you can see, non-traumatic spinal cord injury tend to be less likely to be involved in physical activity, and that could be due to multiple reasons, especially since atraumatic spinal cord injury typically results from higher disease burden, such as malignancy or infection or other mechanisms that may make it harder to exercise, but could be an interesting area of future research to investigate interventions in that population as well. When it comes to adaptive sports, there was a retrospective cross-sectional study in Germany that was completed in 2009 looking at similarly the traits of who is active in adaptive sports versus not adaptive sports. And they found 51.5% of their respondents were participating in some form of adaptive sports, hand biking being the most popular. However, the sample did have some selection bias. They did include a good portion of respondents from the Adaptive Soccer League in Germany, which definitely inflates the numbers, but at least gives us a decent baseline of the traits and predictors of sports participation. One of the largest predictors was participation in sports prior to spinal cord injury, which makes sense that if you're interested in sports before your injury, you'll be interested in sports after your injury, as well as being employed and paraplegic. And so I think this can be an easy population to target for our adaptive sports programs in Minnesota and the greater Minnesota region. I know we have a lot of different programs. I volunteered with the Courage Kenny Adaptive Cycling, and it's great. So I think getting these individuals who are former athletes or current athletes involved in these programs early can be an easy way to increase physical activity in individuals recovering from spinal cord injury. And then the study also looked at quality of life, and they did this through total physical quality of life, social quality of life, psychological quality of life, and context-referred quality of life, which is how these individuals relate to societal norms and feel connected with society as a whole. And they found that there's a correlation with adaptive sports participation and increased quality of life in all four of these domains, and found that fitness, fun, and health were the top three reported incentives for exercising. When it comes to the benefits of physical activity in individuals with spinal cord injury, trials that actually assessed increases in physical activity found increases in quality of life in multiple domains, including emotional quality of life with decreased depression, physical quality of life with decreased pain scores, and then life satisfaction and health behavior increases. They also noted increases in cardiorespiratory fitness, so decreased fatigue and increased endurance, and they typically measure this through peak VO2 and peak work output following the interventions. And so you see both an increase in quality of life and cardiorespiratory fitness following increases in physical activity. When it comes to cardiometabolic benefit and some of the risk factors I discussed earlier, it gets a little bit more nuanced. A few studies looked at lipid metabolism, and one study found an increase in HDL that was clinically and statistically significant following a pilot study of an adaptive body weight walking treadmill study, where they were able to engage the lower extremity muscles in the study, where a arm cycling study for 6 weeks of moderate intensity arm cycling showed no effect on HDL, and both studies showed no significant or clinically significant effect on LDL or total cholesterol. When talking about glycemic control, that arm cycling study did show an increase in hepatic insulin sensitivity and lower fasting insulin. However, A1C and peripheral insulin sensitivity were not significantly changed. And there's been a few reported mechanisms for why this might occur. It could be that because you're exercising the smaller muscles in the arms, the biceps and the triceps, compared to the larger muscles in the legs, that you get a lower metabolic response from activation of those muscles. There's insulin-independent glucose uptake with exercises and changes with lipid metabolism to help mobilize fuel to fuel the exercise that's going on. And so maybe because we're not engaging the leg muscles we're not getting those benefits in those cardiovascular risk factors. And I did find one study that was a functional electrical stimulation hybrid cycling study, which you can kind of see the equipment in the photo on the right, assessing just cardiorespiratory fitness, so peak VO2 and work output. And they found no difference between hybrid cycling and just hand cycling in peak VO2 and fitness level changes, but they did not assess LDL, glycemic control, or other lipid metabolism. And so I think an interesting future direction would be to assess a hybrid cycling study that engages some of those larger muscle groups, and how that might affect cardiovascular risk factors down the road. When it comes to study design, a lot of studies with physical activity will either measure changes with subjective or objective measures. And so some of the subjective measures is surveys such as the Paralyzed, which you can see on the right, that records activity related to activities of daily living and leisure time physical activity in the mild, moderate, and heavy intensity categories. And then there's objective physical activity, which is typically risk accelerometers, wheelchair odometers, or daily steps, if that's applicable. And one study in 2020 compared the agreement between subjective and objective measures by comparing a wrist accelerometer for 1 week of data compared to the Paralyzed survey for the last 3 days of that week. And what they found via Bland-Altman plots was that the subjective physical activity Paralyzed survey overestimated the subjective sport leisure time physical activity and activity with daily living, which makes sense with reporting bias of some of these subjective measures, but also underestimated short bouts of physical activity that objective measures were better able to capture. And that's because, if you're not aware that you're doing physical activity, you're not going to add it to your daily total, whether that's just moving shortly down the hallway or transitioning or other things you may not register as physical activity. The objective physical activity had some limitations as well. It underestimated weight training because a lot of these are distance-based and certain vectors of exercise. And so that may not translate well to weight training, as well as exercise outside on incline or uneven terrain, since it's requiring that certain vector to monitor the distance. One study did find that if you increase the number of accelerometers, you increase the amount of accuracy of the data that's recorded. However, I've seen in multiple studies limitations with objective physical measurements with technology problems. The burdensomeness of these devices can be bulky and difficult for people to wear, and the cost of having these in your surveys or samples. And so I think ideally, studies would have an element of both, since they kind of complement each other in some regards, capturing physical activity, or at least identifying the limitations and error that comes with both methods of observing and recording physical activity. When it comes to interventions that increase physical activity, there was a meta-analysis done in 2023 that looked at increases in subjective and objective physical activity, and they grouped interventions into 3 groups. There was exercise-only interventions, behavior change interventions, and then combination exercise and behavior change interventions. And what they found was that for objective physical activity, there was no increase in physical activity post any of the 3 categories. And that's because not many of the studies included objective measures, and they had lower studies to include in that meta-analysis. When it came to subjective measures of physical activity, they found that the exercise interventions did not significantly increase physical activity at the end of the intervention. But the behavioral category and the combination category did increase physical activity afterwards. And so that's what I'm going to talk about a little bit more over the next couple of slides, is the methods that they used and the different populations assessed through these trials, trying to understand the behavioral and combination interventions that were assessed. So a lot of the behavior change methods that were used, it was not one simple behavior change technique. It was typically a combination of multiple behavior change techniques used in combination, which can make it difficult to assess which of these is the most effective or necessary to create increases in physical activity. So I'll just go through some of the most common ones and some that seem to be more effective or less effective, but we can't truly say because they were kind of all used in combination. So action planning and coping planning were by far the most common and effective, or seemingly effective, methods. So action planning is creating a plan of when, where, and how you'll exercise during the week, whereas coping planning is assessing the barriers you might face to exercising. So whether that's transportation or being tired after work or other things like that, trying to anticipate the barriers that will prevent you from achieving your goal to circumvent that. And one study found that when you use action planning and coping planning interventions together, they have a greater effect than when they're used in isolation. And so I think that's something we can take away is trying to use both of these interventions together instead of separately can be a reasonable approach. There was also self-determination theory, which showed a large increase of internal motivation, which makes sense because self-determination theory is related to self-efficacy, relatedness to others, and competency and autonomy at increasing internal and external motivation for a task. Some less effective methods was the information-only technique. So just providing individuals information on here are the guidelines, go exercise and complete them wasn't super effective, as well as SMART goals, which is interesting because we talk a lot about SMART goals in medical school as a way to create behavior change with our patients and talking with them to create positive change. And so I definitely learned that there's definitely multiple ways to do this with patients and target populations, and trying to look at the data to be most up to date on that is the best way to create sustained change and the behavior you're interested in. When it comes to the timing of the intervention, post-spinal cord injury, it seems to have some effect on intervention efficacy. So for the chronic spinal cord injury population, it showed no difference in subjective physical activity for the exercise-only intervention, which isn't surprising. That's consistent with the meta-analysis. However, that was one of the two studies included in the subjective category and might have limited their results as well. When it comes to the combination or behavior-only interventions, it didn't seem to also increase subjective or objective physical activity in this population. When you compare that to the acute rehab unit-based interventions, the combination and behavioral interventions seem to increase subjective and objective physical activity 6 and 12 months post-discharge. So this might indicate that the timing of the intervention matters, and targeting individuals with spinal cord injury close to the time of their injury within a year or two might have greater potential for change compared to 10 years down the road when they're habitually more sedentary and it might be difficult to make those behavior changes down the road. Another thing that I was interested in was the efficacy of a virtual versus in-person study design, and whether virtual programs were able to get the same cardiorespiratory changes as the in-person highly monitored trials. And what I found was it depended on the methodology. So some less effective methods of home studies or virtual intervention was the exercise only information or just giving them equipment. A lot of these used like desktop arm cyclers to exercise at home, and that didn't seem to be super effective. Similarly, SMART goals and motivational interviewing didn't seem to be super effective in this setting, whereas social support from peers through social media or chats or apps seemed to provide some sort of camaraderie and a sense of community that helped increase physical activity, as well as using social cognitive theory, self-determination theory, and action and coping planning methods of behavior change. And when those were implemented, there was an increase in cardiorespiratory fitness. It did increase leisure time and moderate vigorous physical activity, and did show increases in quality of life, demonstrating that virtual interventions can be very effective. And I think it helps to overcome some of the limitations of in-person interventions. A lot of those in-person trials had increased rates of attrition bias due to loss of follow-up because of transportation issues or other barriers with their facility that may be closing prematurely. And it may not be as practical as virtual interventions because once the intervention ends with an in-person setting, the participants lose access to what they've been using to exercise and create behavior change. And it might be harder to re-implement that at home, whereas if they're exercising at home to begin with, it might be easier to sustain that over time. And then just a side note on the importance of community involvement. There was one study, randomized control trial, that showed the largest increase in subjective moderate vigorous physical activity during their intervention. They used the HAPA model of behavior change, which essentially is a multi-component intervention that tries to increase health positive behavior. And so this case, getting rid of sedentary and increasing physical activity. But what was unique about this study was that it was co-developed with individuals with spinal cord injury, in the intervention, the methodology, and kind of the trial design. And other studies mentioned collaboration with individuals with lived experience, but typically this was in a more minor setting. Informational pamphlets was typically the most common example, and we know that those aren't as effective as more robust interventions. And so I think this just provides good evidence that truly involving individuals with lived experience in research design and research interventions helps to create a larger effects, because they know the barriers that individuals face, especially locally. Minnesota may be different than other parts of the country. And so involving them in the research process, I think, is crucial to creating larger outcomes. So kind of the key takeaways that I got away from this research experience was that psychological or combination interventions were more successful to increase physical activity for individuals with spinal cord injury. Co-development with individuals with lived experience can help improve outcomes. Acknowledging the methodology of your research. So in this case, subjective and objective physical activity measurements, being aware of maybe the over-reporting or under-reporting of physical activity. That exercise benefits quality of life and cardiorespiratory fitness. And I think that there could be exciting new avenues in cardiometabolic research as well. That at-home and virtual exercise programs can be effective and maybe more practical than in-person interventions. And subpopulations that may warrant additional studies include the non-traumatic spinal cord injury community, as well as the timing of intervention, whether that's in the inpatient rehab unit or chronic spinal cord injury, and then tailoring adaptive support programs to former or current athletes to help get them involved in the local programs that we have. The limitations of the studies that I looked at, a lot of them had small sample sizes. Again, I mentioned this a little bit earlier in the presentation, but they had variable definitions of inactivity. And so the inclusion or exclusion criteria may have been variable. And if you include too active a population at baseline, it may not show a large change with your intervention because they're already meeting the guidelines to start with. There were some transportation issues. The lengths of studies and follow-ups varied widely. And I think the biggest limitation is that the studies in the meta-analysis used multiple behavioral interventions at once. So we can't say which of those is truly essential to create the increase in subjective physical activity. We don't know which of those might be the most effective and what we should be focusing on, and maybe which of those in that combination isn't effective and it actually isn't contributing to the increase in physical activity. So I think better studies need to be designed and assessed. And on that note, I'll transfer it over to Dr. Monden to talk about research design in this field.
Thank you, Michael. Great job and great segue into the next part of Grand Rounds today, where I'm going to talk about rethinking how we conduct randomized controlled trials for physical activity interventions. And as Michael talked about, and he gave an overview of one of the recent meta-analyses evaluating the effectiveness of 15 randomized controlled trials to increase physical activity in adults with SCI. And that meta-analysis concluded that exercise interventions alone are ineffective and that complex multi-component interventions are necessary to sustain behavior change. But unfortunately, since those 15 studies were conducted using the treatment package approach, with exercise interventions delivered either alone or simultaneously with other components, so various, as Michael mentioned, like maybe SMART goals, motivational interviewing, and action planning all in one, we're unable to determine which intervention component is necessary to actually sustain behavior change related to physical activity. So to bridge that gap in our knowledge, and I think to advance the field, I have come to learn and get trained in the multi-phase optimization strategy, or MOST framework, and this comes from implementation science. And that's what I'll be talking about today. It's a bit of a different approach to intervention design than we're used to. Zoom is getting in my way, sorry. So if we think about, how we typically design studies, we typically use a randomized controlled trial. That's what we've all been trained in. That's what we're comfortable doing. And in a randomized controlled trial, we put all the components into one intervention and then compare the treatment to the control group. But if you take a second to really think, what is it do we really learn from an RCT? So we can learn if a treatment package is clinically or statistically better than a control treatment. However, we can't learn which components are making positive contributions to the overall effect of the intervention. For example, some components could be doing nothing or even having an antagonistic effect on another component. I'll be talking a lot about intervention components today. And an intervention component is any piece of an intervention that can be separated out for study. It's a part of the intervention included for treatment purposes. So for example, intervention components could be cognitive behavioral therapy, motivational interviewing, SMART goals, or any other type of intervention to increase behavior change. It can include things like text reminders or maybe even gamification. So back to this question of what can we really learn from an RCT? Even though an RCT is successful and shows a significant effect, it can't tell us whether the inclusion of one component has an impact on the effect of another component, whether a component's contribution justifies its cost or burden, or how to make the intervention more effective, affordable, scalable, or efficient. So oftentimes when we're doing these RCTs and building these interventions, they're very bulky and expensive and difficult to implement in the real world. On the other hand, an RCT that does not show a significant effect will not tell us whether any components are worth retaining, whether one component has a negative effect that offsets the positive effect of others, or really what went wrong and how to do it better next time. I know that I've had RCTs that have failed, and it's always such a shame because it's like maybe something worked really, really well and something worked really poorly, and the effects just kind of got washed out, and we can't tease those apart when we use that classical treatment package approach where everything is delivered in one package. So MOST is an engineering-inspired framework for optimizing multi-component behavioral, biomedical, and psychosocial intervention. It integrates ideas from a number of fields, including behavioral science, engineering, multivariate statistics, decision science, and health economics. And the goal of MOST is to optimize multi-component intervention. There are 3 phases of MOST with the goal of optimizing, like I said, these multi-component interventions, and those phases are preparation, optimization, and evaluation. So the preparation phase is when you're developing your intervention. This is where you identify candidate components, either from the literature or from a theoretical perspective. And the preparation phase is also where you should be creating and revising a conceptual model, because it's this conceptual model that will inform the rest of the research process. So taking ample time to build a solid conceptual model is key to informing the optimization stage. And you should think of this conceptual model as a blueprint or a living document that you refer to and refine throughout the research process. The next phase, optimization, is when you actually conduct a randomized trial to determine the effectiveness of each component on your intervention. Optimization is the process of identifying an intervention that provides the best expected outcome obtainable within key constraints imposed by the need for affordability, scalability, and/or efficiency. So what this is saying we want to come up with an efficient intervention that we know isn't too expensive or too burdensome or too hard to implement in the real world. So there are many trial designs you can use in the optimization phase, but the design I'll be focusing on today is the factorial trial, which I'll talk a little about later in the presentation. So depending on the results of the optimization trial, you may have to go back to the drawing board in the preparation phase and refine your conceptual model. Or if you identify intervention components that meet your optimization criterion, you would move on to the evaluation phase, where you would confirm the effectiveness of your optimized intervention with an RCT. However, there is some debate among researchers who are much more specialized in the MOST framework than I am about whether an RCT is actually even really necessary after you go through a fully powered optimization trial. One thing I do like to mention, importantly, most of the framework, it is not a design. So many people will say, I'm conducting a MOST trial. That's incorrect. MOST is simply the framework. Within the MOST framework, you conduct an optimization trial to determine the components to test in the final optimized intervention. So I'm just going to talk a little bit more about this conceptual model. When I started learning more about MOST, this is what really kind of hit home to me in my intervention development, is that at some point in my research journey, I sort of got away from really coming up with a well thought out conceptual model and really treating it as a blueprint. So in behavioral science, a conceptual model serves as a representation of key factors and relationships that influence human behavior. And these models are essential tools for us to understand, predict, and potentially modify behaviors. And the MOST preparation phase is focused entirely on developing a well thought out conceptual model that will serve as a roadmap for understanding the underlying theory that will guide the intervention development process. And developing this conceptual model involves identifying the essential components of the intervention that will be critical to achieving your outcomes. And these core components should be based on the conceptual model and evidence-based practices. So we use conceptual models to guide research design and generate testable hypotheses. And they can also help us understand the underlying factors that may influence behavior. And it provides a framework for which we can develop more targeted interventions. And this is especially important for evaluating the effectiveness of multi-component interventions. So here are the pieces that comprise a conceptual model. So first, the various intervention components are identified for both the intervention and control conditions. Then based on theory, you identify causal pathways through which the intervention components are hypothesized to influence the desired outcome. So what is the mechanism of change? And then you identify potential moderating factors that may influence the effectiveness of the intervention. And finally, you determine the outcome measures that you'll use to test the effectiveness. So best practices for developing conceptual models include grounding the model in theory and clearly defining and measuring the specific outcomes of interest. And it's also best to integrate multiple perspectives or to use an interdisciplinary approach. And really, this is a great opportunity for co-development. So I would highly recommend including interest holders, people with lived experience, clinicians, researchers in this process of building a conceptual model. And then finally, the purpose of the conceptual model, or one of the best practices, is to explicitly outline the expected relationships between the constructs, mediators, and outcomes. So this is an example of what a conceptual model might look like when we use the MOST framework. And then this is an example conceptual model for a very basic potential physical activity intervention that I put together for the purposes of this presentation. But I'll get into the details of this conceptual model in just a little bit. So I'm going to move on to the factorial trial. So this is the optimize it. You've done your conceptual model. Now we're moving to optimization, where in the MOST framework, oftentimes we use a randomized factorial trial. So MOST is governed by something called the resource management principle, which states that we as researchers must always seek to make the best and most efficient use of available resources when obtaining scientific information. And the principle states that we must conduct studies that give us the most information, produce the most reliable information, and move our field forward in the fastest way possible. So to put this into context, I'd like us all to think like engineers for a moment. So engineers use the resource management principle. That's where this construct comes from, and they use this when they're designing products. So if you're an engineer and you're tasked with creating a faster and lighter iPhone, where do you start? So the components of the iPhone you might look to manipulate to make it faster and lighter, maybe something like screen size, computing power or CPU, storage, and battery life. And your optimization criterion is that this new optimized iPhone cannot cost more than $1,500. Next, you would test variations of these components to see which combination gives you the best results and meets your optimization criterion of not exceeding $1,500. So CPU and battery life are probably the biggest factors relating to cost and weight, whereas screen size and storage are areas in which you may be able to save costs. So you would manipulate the different levels of these components to achieve the fastest and lightest iPhone for under $1,500. Now, how would we approach this problem as behavioral scientists? We would likely hypothesize that larger, faster, and more screen, CPU, and battery life are all better. And then what we do is we conduct an RCT with the classical treatment approach, where we put the highest level of all of these different components into a treatment package, and we conduct an RCT. And we would test this new, faster, lighter iPhone against the current iPhone. And what happens if this experiment is a success? The iPhone is improved. So first of all, even if the experiment is successful, we wouldn't be able to exactly understand why it was improved. Was it one single component or multiple components that made it better? Or maybe we made it faster and lighter, but we exceeded our key constraint of $1,500. Or on the other hand, we conducted the RCT with the whole treatment package and found out that the iPhone was worse. So unfortunately, because we used an RCT, in the classical treatment approach, we can't know why it's worse. So perhaps there are antagonistic effects between some of those components. So for example, the bigger screen might actually be draining battery life. So as a bit of an overview of what I've just gone over, factorial trials are a powerful research design that allow for the systematic evaluation of multiple intervention components simultaneously. And these trials provide insights into the independent and interactive effects of various components, enabling researchers to identify the most effective combination of components and a multi-component intervention. So I'm going to walk through the first two phases of the MOST framework, now I combine them, preparation and optimization. In the preparation phase, you would develop your conceptual model. And this is the example I showed a little earlier in the presentation of a very basic multi-component physical activity intervention. But to walk through this model, this conceptual model, we're saying we're going to have in this intervention 3 components: motivational interviewing, physical activity, and text reminders. We talk about the mechanisms of action by which these would work. These are our mediators and how we're going to measure them. We explicitly state the outcome, so increased physical activity. How are we going to measure that? And oftentimes we also talk about some more distal outcomes, which is where maybe increased cardiovascular fitness or even increased cardiometabolic health might come in. So the example I just provided in that conceptual model is an example of a 2 to the 3 factorial design. This is because there are 3 components, each with 2 levels: yes, no, or they receive it or they don't receive it. So an experiment with 4 components with 2 levels would be a 2 to the 4 factorial design. So the first thing to note in a factorial design is that we're not comparing experimental conditions or the rows. So we're not comparing participants in condition 1 to those in condition 2 and so forth. In a factorial design, the same participant may be a treatment participant for one component and a control participant for another. For example, a participant in condition 4 would be a control for the physical activity and text reminders because they're set to no, they don't receive those, but not for the motivational interviewing because they're set to yes, they do receive that. Whereas in experimental condition 2, participants only serve as controls for the text reminders. So they don't receive the text reminders, but they receive the first 2 components. So this is different from an RCT because we're not comparing each experimental condition to condition 8, where all participants are set to no. So to explain this, it helps me to look at the factorial design table this way. So it may be easier to see that for component 1, motivational interviewing, conditions 1 through 4 are the treatment group, and conditions 5 through 8 are the control. For component 2, the physical activity program, conditions 1, 2, 5, and 6 are the treatment group, 3, 4, 7, and 8 are the control. And for the text reminders, 1, 3, 5, and 7 are the treatment group, and 2, 4, 6, and 8 are the control. So again, the purpose of the factorial trial is not to compare the means of each of the 8 experimental conditions to each other. Instead, the experimental conditions are combined in various ways to explore the main effects. So due to the way conditions are combined, each main effect is based on the entire set of participants, in this case, 112. So to evaluate the main effect of each intervention component on the change in the outcome, you would use a factorial ANOVA to analyze the effects of 2 or more categorical independent variables, the components or factors, yes or no, on a continuous dependent variable. So to test the effectiveness of the motivational interviewing, the main effective conditions 1 through 4 are compared to the main effective conditions 5 through 8. You would do the same for the physical activity program, and again, the same for the text reminders. Now, when you power a factorial trial, you can also power it to detect interactions, and interactions will tell you whether certain combinations of components are more beneficial or if they make the intervention less effective. So for example, we might find that physical activity programming works best when also delivered with motivational interviewing, or we might find for some reason that adding text messaging makes the intervention less effective or it has an antagonistic effect. So for example, recent behavioral research using factorial trials has actually shown an antagonistic effect of text message reminders that has emerged after the pandemic, which they hypothesize is due to information fatigue. When you're done your optimization trial, this is where you have to then make some decisions about which components you're going to include in your optimized intervention. So decision making is based first on main effects, followed by careful consideration of interactions. And what you need to ask yourself is, what is the minimum main effect a component needs to exhibit to indicate that it should be selected for the screened in set? So typically you'll use less stringent criteria for including a component, so a lower main effect, than you would in an RCT, determining if an intervention is effective. This is because you don't want to risk out screening any component that is potentially effective, so we cast a wider net and loosen up the criteria. And this is the difference between the conclusion-based priority that we typically use in a randomized controlled trial and a decision-based priority that we use in an optimization trial. So in addition to identifying effective components, you also want to make sure that your intervention components are cost-effective, feasible, and prioritize participant preferences, which is where the co-creation of these interventions is really crucial. And because the ultimate goal of the MOST framework is to design optimized and efficient interventions that have a higher likelihood of being implemented in the real world. So I spoke really quickly because I realized I'm running out of time. But the takeaway today is that factorial designs are really efficient, and they're especially efficient at weeding out ineffective components, and from those components that remain, identifying the ones and the component levels that will make up the optimized intervention. So what I propose is that when designing physical activity interventions, we step back to the preparation phase and be very thoughtful and methodical about the components we want to include in our interventions, and then go through the process of optimization. I believe this will lead to better interventions that are more efficient because we won't be including components that aren't effective or maybe even antagonistic. And this will also allow us to carry information forward about components that we know work or don't work from one trial to another. For instance, if we find that SMART goals or motivational interviewing aren't effective, we don't need to keep including those in treatment packages. So it scales down the intervention, makes it less bulky, and makes it more efficient. And with that, I will open it up for questions. And I'm sorry I spoke so quickly.
Great presentation, you guys. Really well done. And yeah, like Kim said, if you have any questions, we invite you to type them into the Q&A spot, and I can read them aloud as they come through. As we're waiting for questions, I just want to say, Kim, I've heard you give talks on this topic a few times now, and every time I hear it, it just really excites me as thinking about intervention development and how we can bring this to rehabilitation science. I think it's a different way to approach, and I'm excited to take this and run with it.
On that note, rehab medicine, PM&R, is really behind in some of these more advanced trials that we like SMART trials, adaptive trials. We're kind of behind the rest of, or a lot of other fields like HIV, cancer, in the way that we're building our interventions and testing them. And in trying, I wrote a commentary on using MOST in rehabilitation medicine, in biobehavioral research. I got a lot of pushback. It was rejected from archives. It ended up getting accepted in rehabilitation psychology, but people just don't understand the need for it, and there's just kind of a gut reaction against it. But if you want to learn more, there is a lot of information. I should have included the link. If you go to CADIO, CADIO.org, maybe Angie can put it in the chat. You can learn a lot more about the MOST framework and factorial designs.
We have a question all the way from the UK, Dr. Jane Duff. Thanks for joining us. She says, hey, she says, hey, Kim, great presentation. Thank you. Recognize that whichever outcome measure you want to use would relate to the preparation phase. Is there any you have come across that you favor?
In the physical activity intervention?
Yes. She says,
so, okay. So I have not actually proposed an intervention for physical activity in a study. I've not conducted one, but I don't know, maybe Michael can say from the literature, which are some of the better outcomes. I know like the para-SCI was initially used for subjective reports, but now the recommendation from Kathleen Martin-Guinness and her lab is to use the leisure time physical activity questionnaire because the inclusion of ADLs wasn't actually accurate. But what else did you learn from the lit search, Michael?
Yeah, I can't really speak to which of the surveys is probably more accurate than the other, but I saw kind of a shift towards the leisure time physical activity, and I think there's an adaptive form for spinal cord injury as well. So yeah, that's all I really have to add to that.
And then in that conceptual model, maybe I can scroll back to it. So here, I mean, you can even say, you know, it's this increased physical activity, Jane, that then knowing our interests, our mutual interests, leads to better quality of life or decreased depression or higher perceived health status. So this is a pretty basic conceptual model. You can make it a little more difficult. And I also didn't get into the moderator here of level of injury, which might be something you want to take into consideration, whether it's paraplegia or tetraplegia is probably going to impact the amount of exercise, moderate to vigorous exercise someone's going to be able to achieve, which is going to impact your outcome.
and Jane noted it would also be thinking about like self-efficacy and mood.
Yes.
Perhaps being limitations.
Yes.
Yeah.
Thank you, Jane. Thanks for attending.
You know, Michael, I want to say that it was a pleasure working with you over the last couple of months, and it's really exciting to know that you are, you know, part of our future medical professionals, and that you'll take this work that you've done in the research elective to, you know, help bring patient-centered care and to your patients. So it's been really great and a really great presentation. We've got a couple more minutes. Any more questions for Kim or Michael?
I do have one comment. So Angie recently got funded by the Craig H. Nielsen Foundation for a postdoc where she will be implementing the preparation and optimization phase, or just preparation?
Preparation phase.
The preparation phase of the MOST framework, creating an intervention targeting injustice appraisals, which is something we study. But this will be the first time, and I say we because I'm her mentor, but she'll be doing the work. This is the first time we'll actually be putting this into practice and co-creating the conceptual model and then conducting, I believe it was a pilot factorial trial.
Correct.
So you can look forward to hearing details about that in the future.
And I included the CADIO website, and you can find more information on training on MOST and all the things that Kim brought up during her part of the presentation.
Oh, I should switch to the last slide.
All right. Hearing it or seeing no more questions. Of course, everyone's free to reach out to the presenters offline, but we want to thank everyone for attending today's grand rounds and apologize if your questions weren't answered. But as I said, feel free to reach out to the presenters directly if you want some follow-up regarding the discussion. The recording for this webinar will be posted soon on the MinSCIMS website with a link to our YouTube channel. And as a reminder, please see the chat information on how to obtain CME credit for attending today's webinar. So at the end of the webinar will be a brief 3-question survey that'll pop up, and we'd really appreciate your feedback. So thank you all and have a wonderful rest of your day.
Thank you.